We were on meeting at 6:37. So then they come and said, let's go to Michiatsi. We showed up at Michiatsi and it was an hour and a half. And they said it's, we just have a lot of parties, yeah. We're trying to get 8:30. So we have to be done. They said about 8:30. They said it's 35 people. It's 2 hours. Yeah. And he did say at Orndorff, and then we got to sit on it. So we like, well, if it's an hour away, I'm telling you, we waited more than an hour. We were the last people to leave.
How are you, ma'am?
I'll come see y'all, maybe.
Sure. We should go out here. Go out.
Yeah, me too. Okay. I'll call her Kim. I'll call her Kim. Say, I want to go to lunch.
Yeah. Let's do Indian this time.
My sister said she.
How are you? Thanks for coming.
Well, she's got an appointment.
I couldn't steal. I just hi and because I have meetings at 12 and at 1.
Okay.
So this is the Sierra.
My sister said.
It's about to be at but the station is correct. So I have meeting with them. So I just would like you to be agree. I did put temporarily on hold the postpartum conditions until we have clarified everything. So it's not closed.
Okay.
It's just temporarily see what we need to adjust because right now we don't know.
Right.
But it's I don't want to keep it open because it's easier to put in
Perfect. Well, good to see you. How's your daughter doing?
Oh, she's doing great.
She's ready for the ballet?
Yeah, they're dancing each evening. They have every day they can, and tomorrow they're playing in Noel. This is the first time for the year. And then Friday is the last time. So they are using the show starts on Saturday.
Oh, wow. 2 days.
2 days.
She must be tired and exhausted.
Well, she's every day we are cooking and she has, no power. She's starting to watch TV and then she's but it's fun, it's fun.
But you have something to eat before you go. You can look
I will
at it.
grab something. Okay.
Hello, ladies and gentlemen. Can you all hear me? Can you all hear me? Is the volume okay? All right. I've been told I've got a very puny, girly voice. So make sure my mic is always on. Just want to make sure I don't go to the restroom with my mic on. Oh, did I say that loud? Okay. Fantastic topic to talk about, but it's very nice, good beautiful day, we're talking about depression. What is the irony here? And I see most of us over here are females, with due respect to two of my very esteemed audience over here, but that itself is a problem. We're going to talk about a depression that affects everybody and anybody across gender, across race, across national origin, ethnic origin. But look, men are very difficult to get interested into hearing and knowing about depression. Let's talk about depression. This is a time of the year many people struggle with more mood problems. But let's talk about basic things about depression. Again, let me see a show of hands. Someone who has struggled with depression, or someone you know close to you has struggled with depression. Absolutely. It is a very, very common illness. By 2020 they say, or 2025 they say, it's going to be the second most common reason for morbidity in the United States after cardiovascular problems. So if you're thinking depression is something we can afford to keep and shove it in the carpet, it doesn't exist, it's not in front of us, it doesn't exist, we don't talk about things, it will not bother us, this is time to change. And it should have been changed a long time ago, but this is time to change. And if you struggle with depression, or have someone close, loved ones who struggle with depression, let me give you something that will open your eyes. If you think you are alone, look at this. Van Gogh, one of the most famous artists you have probably ever walked on the surface of Earth in recent times, in year 200, in 100, 200 years. Almost regarded as the second father of a nation, father of liberty, as they say. Tolstoy, Isaac Newton. These people don't need introduction from me. Hemingway. You probably see him every Sunday. J.K. Rowling, she's probably richer than Queen Victoria now because of the Harry Potter books and the movies. She's more richer than the Queen of Victoria now. Guess what? She's probably the richest woman in the whole world, definitely in the UK. Suffers from depression. Leonardo da Vinci, Michelangelo and Leonardo da Vinci both suffered from that one. He recently died. He was very open about it. This lady has been very vocal about it, more particularly about postpartum depression than anything else. What I mean to say about these folks, and I want you to imbibe and see this, if you're struggling with depression, you are not alone. Depression strikes across, no matter how famous you are, no matter how successful you are, no matter how much money you have, no matter what social status you have, no matter what gender you belong to, no matter what socioeconomic status you belong to, depression permeates and hurts. It's time to be very aggressive about it, talk about it openly, and address it very quickly. I hope to at least start with this small talk about what entitles depression. Because even in a scientific community, depression by all means sadness and being tearful. But depression, clinical depression, as we talk about it, is just more than that. So what the heck is when we say we are depressed, what the heck do we mean? When psychiatrists say you have depression, what the heck do they mean? This is how we're going to talk about it. We talk about introduction, we talk about depression. This is the outline, what we're going to be talking about. Effects of depression, depression with its co-travelers, what are comorbid conditions that can happen. Snapshot depression across nations, as we call it, and depression resources by country and references we're going to talk about. Let's go through very quickly while we are loading up on carbohydrates. Okay, leading cause of disability across the world, as I mentioned. Doesn't matter where you live. It affects everybody, anybody, some more, some less, but it does affect. It is a disorder. It's a disorder. It's not a sign of weakness. Most people who are coming from armed forces, police forces, EMS, they are very adamantly believer that depression and crying is a sign of weakness. It's an illness as real and as open and as obvious as breaking up your leg or having diabetes or hypertension. It's an illness. And like any other illness, early intervention, early diagnosis, early intervention, just like a wound. If you would have a wound, if it's not diagnosed, adequately treated, guess what? It becomes a chronic, oozing out, full of pus, gross, open, raw surface, and an infection. Because you're eating, I cannot be more groggy, but more gorgy on that one. But I want you to imbibe that. That's what depression is doing to your brain, particularly when it's not being treated adequately. And it's a health condition that frequently misunderstood. And of course, as you know, stigma, because it's mental illness, right? Hopefully by this end of this lecture, we have some removal of the stigma that we have. Let's talk about a little bit of facts about depression. As I mentioned, across all ages. Of course, certain ages, certain age groups, certain conditions. For example, women are almost 3 times more likely to have more depressive episodes than men. Why? Women go tsunamis of hormonal changes, be it puberty, be it childbirth, be it menstrual cycles, or menopause. If those hormonal changes happen, it makes them more susceptible to depression. Very important point. It doesn't mean that something women are more susceptible to just because they're women. No. It's because they're having hormonal changes. Men suffer from that too, particularly when they age. When they're having some problems with testosterone levels going down, they're more susceptible to depression. But it's a condition that affects every gender. As I mentioned, it's not a sign of weakness or defect in character. That is something I really want you guys to carry, and when you're talking to loved ones who's resistant to taking treatment, we want to reassure them. We ask you to see a psychiatrist or a doctor, doesn't mean that you're weak or there's some flaw in your character. It's like any illness. If you had a broken leg, would you not get to see a doctor? If you have diabetes, would you not go see a doctor? If it's hypertension, would you not see a doctor to get better? Why not this? Simply because this illness resides in the brain? You want to ignore it? No. It's as real as any other medical condition we know of. Okay, clinically we define depression. There are different forms of depression as we know. The most common one that we talk about, which we say 1 in 5 or maybe less than that, people in the United States will be affected throughout a lifetime, is what we call major depression. We wanted to make the emphasis on, we could call it clinical depression, no. We want to call it major depression just to emphasize the term that how devastating this illness is in terms of breaking down the life, your structure, your livelihood, your ability to function, and for people around you. If you have a loved one who suffers from depression, you probably know what exactly I'm talking about. It is painful to see someone who you love suffering and struggling from depression. And we call minor depression what we used to call dysthymia. This is probably more common than we probably recognized a few years ago. What we mean is that the depression is not as bad that you are completely dysfunctional, but you are just floating down your optimum level. Suppose you are very productive and you do everything on the go, everything gets done, and then after some years, you're not on the go, you're not as down as you would be dysfunctional, but you remain so out of oomph, out of zeal for life. You drag every day, you're able to go to work, you're able to do your work, but your heart is not there because you don't feel like doing it. It's called dysthymia. Very difficult to detect, and probably more devastating because it's very difficult to detect and very difficult to treat. Simply because people would not, they think I'm getting lazy. They think I'm getting old. They think that maybe it's my neighbor, I don't know. They come up with excuses to justify why I don't have the oomph in my life. One of the possibility could be it's what we call dysthymia. By nature, it is a sustained low phase of depression. And the other one, the very popular with the media, bipolar. Nowadays it's a fashion. Everybody who has any mood problem is bipolar. But when we say someone is suffering from bipolar, that means they have 2 poles. And these folks swing from one pole to the other pole. If one pole is feeling very down and depressed and without any energy, the other pole is on the opposite side. Very high energy, very on the go. On the go, go, go actually. A lot of energy, a lot of motivation, a lot of enthusiasm to do things. So why we worried about it? Are we jealous that these people are so happy and so outgoing? No. The problem is when you go to the opposite side of the pole, from being depressed to being on the very high, we tend to make very poor judgment. We are impulsive. We make rash decisions. And on top of that, that upstage is very unstable. So you spend very little time being up and a huge lot of time being down. So you go like a yo-yo, up, down, and you're looking forward to doing something, and boom, something happens. Sometimes you don't know any trigger. And your mood goes very down, to the point that being very excited, outward going, to the point of not able to even get out of the bed. That is bipolar disorder. It's probably more devastating. Suicide rates are probably higher in patients who have bipolar disorder. There are various subcategories of bipolar disorder, but the one I'm talking about is bipolar 1. That's probably the most sinister, most bad consequences about it. Symptoms of depression. It's common across all things. Yes, depression can be the manifested depression, the outward appearance of depression can be culturally influenced. But most of the depressions, as we call by DSM-4, our Bible as we call it, have common risk factors. And let's talk about the risk factors. I mentioned one of them, gender, more common in women. I mentioned because of the hormonal changes. Right? Economic disadvantage. Now people say, if I get rich, I'll be happy. Now we laugh about it and we say, yes, if I hit a lotto, I'll be happy. By the way, people who have won big jackpots, how many of them have committed suicide? Very high. Yes, there is an association of economic advantage and being wealthy with happiness. But it's a J curve. What it means is that you get happy as your wealth grows. But after a certain degree of wealth and social advantage, you don't get as much advantage as it is. You don't get any more happiness. Money gives happiness to a certain extent. After that, money does not make any difference. If you think Bill Gates is happy, then most other people around the world, I doubt it. Yes, it made him happy, it made him more affluent to a certain extent. And that affluence will be just about what affluence we have. What I'm trying to say, in America, particularly in an affluent society like ours, we all have certain degree of economic achievement that is good enough, particularly when you compare to third world countries. I come from a culture where I've seen poverty, dire poverty. When you compare it, it's very difficult to compare that kind of poverty over here. But what I'm trying to say, economic benefits do not give happiness after a certain level of achievement, right? Social advantage, yes. Certain ethnic groups do have social advantage over the other. It's relative. Genetics, very highly. How many times you see that certain features, certain mood problems tend to run in the family? Mood disorders, particularly bipolar disorder, tend to run in the family. If you have first degree relative that is directly connected to you by blood, has history of bipolar disorder, you are 12 to 15 times more likely to suffer from bipolar disorder compared to general population. So yes, it is always advisable to know and test the person who you decide to breed with. That kind of sounds odd, but yes, genetics plays a very important role. Genes do matter, particularly in case of mood disorders. Don't go by the height and the blue eyes and the flashy Camaro sitting outside. Look at his family background or her family background. Exposure to violence. Yes, the more exposure to trauma you have had in your early life, and I'm mostly referring to abuse, chronic stresses, particularly before the separation, loss of a parent, particularly before the age of 11, has known to independently influence and affect development of depression. Separation and divorce, absolutely. Chronic illnesses, independently. We used to think, okay, people who have epilepsy, people who have hypertension, people who have diabetes, they have so much restrictions in their life that they are likely to develop depression anyways. No. What we've seen in chronic conditions, particularly like diabetes, endocrine problems, they independently cause certain changes in your body that lead to depression. For example, diabetic patients, 70 to 80% of the patients with chronic diabetes, particularly when you start developing chronic neuropathy, diabetic neuropathy, you're likely to suffer from depression. I'm seeing there are no physician friends out there except for my colleague over here, but people, and any endocrine person will tell you that it's very difficult for patients who have chronic conditions to treat them to remission, be it thyroid problem, hypertension, or anything else, if you don't treat their mental illness. Because patients with chronic conditions have very high rates of depression. Right? So chronic illnesses, separation, exposure to violence, exposure to separation, bereavement-related issues, all independently lead to depression. Again, there are other risk factors. People having substance abuse problems, it's a two-way street. It's not the chicken and egg kind of thing. Which one came first? But from what I see is that mood disorders, mental illness probably is much more likely to come first. And people by nature or by random experimentation find that some of the substances benefit more than that, and they get hooked onto it. Again, there's nothing absolute in biology, so most likely it's the mental illness that's causing problems. If we have associated anxiety, particularly chronic anxiety, leads to depression. A lot of times we find that families, kids with depression, what we find in the parents, high rates of anxiety. Anxiety and depression are like close buddies, like Siamese twins. You cannot have anxiety without depression, and you cannot have depression without anxiety. Even the medications that were designed to treat depression are known to independently affect anxiety. Right? So be aware of that. Now, depression, of course, you have diabetes and HIV, we already talked about it. Depression, as I mentioned in my last talk, is the single most important reason for people who commit suicide. 90% of the people who actually commit suicide have undiagnosed, untreated depression. If you eliminate depression, along with some certain factors, of course, suicide rates are bound to go down. And particularly in a younger population where the availability or the awareness of depression as it appears in younger population is so difficult, we are losing our young ones, our bright ones, our future, left and right nowadays, simply because of depression, untreated depression, and to suicide. Okay, what can you help? What can you know can help you? Is a serious illness. It is across all ethnic groups. It's an illness of brain. It's not a sign of weakness. It's not a sign of character pathology. It is just an illness. Let's goddamn treat it. Let's put that. We have to have a certain degree. I mean, we will be up in arms if something like that happened to. Suppose if we had something in a society where kids are getting in accidents, the head injuries happening, and there's no doctor available to treat head injuries. My God, we'll be up in arms, probably going to Austin next hour. Why aren't we having the same degree of anger and run towards not getting adequate mental health for our families, of our loved ones, and for everybody else? Diagnosing depression. Now, we're talking about this is of the criteria as we call about major depression. What are we calling about it? It's persistent sadness. Now, we all get sad, we all get bummed out, we all have good days and bad days. But what we're calling about persistent means most of the day, predominant of the day. Most of the day, predominant of the day for continuous 2 weeks. If you have 2 weeks where you have most of the days of the 2 weeks, and most of the day during the daytime, like half the day, 3/4 of the day, you feel bummed out. That is persistent sadness. Feelings of hopelessness. There's nothing called hopelessness. There's always a choice. But how we look, is the glass half full or half empty? If you continue to have the ability to look, everything is half empty, it's probably you're wearing the glasses of depression. If you know what I mean. Just with your depression glasses, all you see is hopelessness. Loss of interest and pleasure. Hobbies you like to do. You used to look forward to bowling on Friday nights. You used to look forward to having movie nights on Friday. Go out and eat on Sunday. Now it's a drag. You do it mechanically. You rather dread going it. Loss of pleasure. Sign of depression. and other activities, decrease energy. Now there may be a lot of reasons behind you have decreased energy. But if you have ruled out the normal causes, your blood work looks normal, your thyroid looks normal, your iron looks normal, your hemoglobin looks normal, you're eating well, all your body indicators showing that nutritionally you're okay, but you know what? It feels so tired even to raise your arm, to get out of the bed, to take your dog out to walk. That is a sign of depression. Difficulty concentrating. I used to get those jobs done in 2 hours. I used to remember like that, everything I was taught to. Am I getting dumb? Am I getting dementia? I read something, by the time I read the end of the paragraph, I forget what I read up on the top of it. I look at someone's talking to me, I try to listen what they're saying, I keep on staring at them, and they ask me, did you understand? And it's nothing there. That is depression. Loss of concentration. And what you're going to have is depression is real. Summarize, that's what we want to say. There are many signs of symptom depression. Depression is not homogeneous condition. It's got, every person can have a different. Now I'm not saying every person will have the same symptoms. Some people will have more symptoms predominantly compared to others. It's all depression. When you go to apples, when you go to buy apples, some are more red, some are more white, but they're still apples. Same with depression. You may have one symptom predominant to the other ones. That doesn't mean you don't have depression. I'm saying that depression comes in different flavors. And again, that's our job as a community, as providers, as family members to be aware of what resources we have. We'll talk about it in a minute, what resources we have. Now, when I say it's a bold statement, there's no cure for depression, let me take that back because it comes across wrong. Depression is treated, but, it's a big but. It requires treatment not just with medications. In fact, depression is treated only 30% with medications. What is more effective is definitely counseling. In fact, a lot of studies have shown that counseling, good counseling, what we call cognitive behavioral counseling, has got CBT as we call it. And we have therapists. Dr. Sheets was here. She specializes in that. Dr. Blanchett, you probably see her sometime in one of those talks again. These people specialize in that kind of counseling. And they're seeing, what they've done is that the brain, they did MRI studies. People who are going through counseling have the same changes in the brain in response to the counseling as they have changed the brain in response to medications. Counseling can be that powerful. You don't want to take medications? Fine. Don't have to take medications. But I'll tell you this, when you combine medications with counseling, the effect is more robust and the effect of treatment is more faster and probably longer lasting. Yes, medications are not perfect. Medications have a lot of side effects. They come up with problems. Agree. But when you combine with counseling, medications can do wonder. I never advocate medications as a sole agent for treating depression. No, even if the medication, if your treatment is getting better with medications, you don't understand, you don't have the tools with medications to prevent relapse of depression. Not a very effective way of treating depression. There are a number of, this is a busy slide, I just want to tell you, there are a number of treatment modalities available. In the last 20 years, we have come miles away from what used to be in 60s and 70s and 80s about depression. Medications are helpful. We had a number of different medications, number of different non-medication intervention, be it what we provide here in Midland Memorial Hospital is what we call ECT. I provide ECT. Basically a form of intervention where we use a very small current under anesthesia to cause the brain to go into convulsion. And that is very therapeutic in treating very severe form of depression. It's like someone opening your brain, putting a hand in your brain and kind of wake up kind of thing. Get the juice going. That's particularly what we're doing. In fact, we cannot open the head. We put a small electric current in the head and it kind of soups up, kind of stirs up the brain with all the neurochemicals. Known to be extremely helpful. And nowadays, we have no problem giving any forms of intervention. The problem is people not seeking help. People not recognizing their depression. And the barriers. Let's talk about the barriers. And I want to hear from you. If you have a loved and dear ones who suffers from depression, and you tried very, very hard to get him to her to seek help. Let me ask for you guys, what has been the most important barrier to get him or her to treatment? Anyone?
It's the fact that they won't listen, they dismiss it, and you can't give them the word it was.
So they will listen, they'll deny the fact that they have depression, particularly if you have a younger one, younger age. It's very difficult. Extremely important. Yes, ma'am.
How generally tell somebody that they need somebody they need
Yeah. If I knew that as a very effective way, I would be probably sitting in a yacht in Mediterranean with my own private yacht. The thing is that how to effectively treat or address somebody who needs help, who doesn't want to help, doesn't recognize depression. And I'm assuming this is a male guy, because males, as we know, our brains get fried with all the testosterone. But it's very important. Males suffer from depression particularly, and the fact that they would not listen to the fact that they need help. One of the strategies they have to do that is that males, of course, we have egos, right? If you tell them you need help to get better, they probably will never listen. If you tell them that if they can do certain job effectively, if they had some more juice in their brains. And of course, that's why I never use the term mental. I never use the word psychiatry. I use emotional health, or behavior intervention. Because these two words, psychiatry and mental health, got such a stigma to it. The moment you use the words, immediate barriers come in. So I would approach your significant other or anybody who is, depending on what they're struggling with. If it's a child who's struggling with school, not able to focus, remember, I would say, would you like to get your work done or remember things and do as well as you were doing before with very little help? Is it possible that you could do better because emotionally you're not feeling well? Make it a model of an illness rather than a model of weakness. Is it possible you're struggling with emotional concerns that would be helpful by addressing with either medications or therapy? Get them into the door. That's the most important. If you have loved one that you can get into the door, that's half the battle is won. Because once they get in the door, we can talk about counseling issues, we can talk about medication issues that can be very helpful. Let's talk about more when we finish, and I can give you some more tips how to talk about it. There are many effective treatments for depression. Most people with depression can get better with treatment. Most people. Again, our treatments are not perfect. Certain treatments have higher success rates compared to others. Medication we design, the first line intervention, if you have antidepressant given, up to 50-60% of patients will get immediate benefit. The rest 50-60% tend to need some more extra help. So yes, it's not a perfect science, it's more art than science. In fact, we need to try a number of trials on antidepressants before we find the right one to adjust. Right? It's like the dating scene. You don't marry the first person you meet in the bar. I'm just joking. I'm just saying that you go to dating, you select the right one, right? The one that works best for you. So joking aside, what I'm trying to say is that it is a hit and trial method. There are no blood levels. There's no imaging study that we can do to figure out, okay, this medication will work with this person. Right? We have to try them before we get better. It's a hit and trial method. Living with depression, and I want to do a separate talk about it, how practically we can take certain steps, how to live with depression when we have this kind of illness doing it. Taking care of yourself, this is easier said than done. It's very easy said than done. A lot of you guys are nodding head, and I can understand that why you're nodding head. We just know it, this is what is right for us, we know it's right for us to exercise, we know it's right to eat well, we know it, but how to do it? I can give you a very secret formula which Nike stole from me. I wish I had copyright on it. I would not be sitting here. I would be in my yacht, in the Mediterranean. Just goddamn do it. I've added goddamn. The thing is that without thinking, mechanically gotta do it. If you think about it, if you give your mind a second thought, to, maybe I can do it in the evening. Maybe I can work out in the evening. Maybe I can do this job later on. No. If you thought about that, plan your day before in the evening. I'm going to do this. And stick with it, even if you have to drag yourself by your own collar. Stick with it. Initially, it will be difficult. I guarantee it will be like climbing Mount Everest. But I can almost promise you it will get easier with time. So one of the secrets of it is that mechanically want to do it. Of course, a lot of times it may not be possible, and that's where medication and professional help comes in. Seek out families and friends. It's very, very important, folks, that depression by nature wants us to be isolated. And that's the worst thing you can do while one is depressed. In fact, you should have a steady source of support, close friends. Invest in your friends, as I say. These are the friends you can turn to when you're feeling down. Hey, I'm feeling down. Can we do something this evening? I'm not doing well. What can we do today? You should have friends, a couple of numbers on your telephone, your speed dial, you can call, hey, I'm not doing well. What can we do? Maybe you can go out for lunch. Even a small help that someone who's able to yank you out of the bed and do something is good enough. You need to have support system, either peer support system, friends and family, and of course, support system like this one. This is helpful. Talking about it, not putting it in the back burner, talking about it, dealing with your demons is very important. Okay? And of course, living with depression can be very difficult. Someone who has suffered with depression can understand what I'm trying to say. You need a lot of support to maintain a healthy lifestyle. Stick with your treatment. Family members and close friends can play a critical role, as I mentioned. One of the biggest things that we recommend is you can possibly do is to invest in close friends that you can call. That is one of the immense, non-judgmental. Possibly that person may have his or her bad days, good days also. But that is investment worth in gold. Someone you can relate to, someone who can check on you. Someone who calls you back if you have not called them for 2 days, 3 days. Now that is an excellent source of support. And you should invest in this. Doesn't matter who he or she is. And of course, you have to take charge of yourself. If you cannot take charge of your illness, cannot happen. If you don't like that doctor, fire his ass. Go to another one. Pardon my French, but I want to address the fact that seek treatment. It's possible you may not like a therapist. It's possible it may not work with one psychiatrist. Find another one. But don't stop treatment until you find adequate relief. If you're not satisfied with it, customer comes first. If you're not satisfied with it, at least give that person a chance. Give them a couple of therapy sessions. Give them a couple of, hear. If they're saying critical, it is something I need to hear. Have an objective look at it. As a psychiatrist, I can tell you, this morning I saw a patient who was very angry, came at 8:30 and sat down on my couch and said, I talked to you last time 2 weeks ago, I've been having a tough time. I wish you would not talk to me like that. Up in the frame, I almost fell off my chair. 8:30 morning, I was hardly awake. No, seriously. No, but the point was good. I mean, sometimes we have to be paired. As we are human beings too. Most psychiatrists, as you know, they either have their own mental illness problems, or they have someone. We don't go into this line because we want. There's no money there. There's no fame there. There's no glamour here. Why are we coming to do this kind of work? Either we suffer from mental illness, or we have close family members who suffer from mental illness. Right? So we want to help. Sometimes we say things that are not very kosher. Agreed. So if that happens, bring it up. What she did was, she brought it up in the open. This is what happened. You said something about it, I didn't agree with it. It hurt me, it hurt my feelings. I apologize. Made some clarification what I meant to say. I said she was very bossy. She is bossy. So she hurt her feelings, I had to just remold it. I said, you're very assertive. That went well with her. Okay. Helping someone with depression, right? Talking and listening. This is a time for you to give your attention and your full attention to the person. Listening. Understand where the person is coming. Doesn't matter if he's a child. Doesn't matter if you're a spouse. Listen to them and talk to them. What is going on? This is happening. What can we do differently? Understand depression. Understand, do your own homework. If you don't understand how depression looks like, how are you going to help your loved and dear ones? Do your own research. Support the treatment. Depression treatment is very difficult because they have not many benefits. It takes a long time for the medications to work. And you have a lot of side effects. And getting help in the healthcare system. Texas, mental health, I don't need to say anything more. We are 49, probably 51. I don't know. If you had a 51 state, we were 51. It's very difficult. Getting help, getting into healthcare system, getting into appointments. Standing in line, making appointments, making phone calls is difficult. Help them with making appointments and difficulties. Helping with day-to-day activities. Let me help you get your shower going. Let me help you make phone calls so that you don't have to worry about let me go and fill up your gas tank so you don't worry one little thing about it. Small things will go a long way. Supporting regular activity. One thing you can do is keep encouraging, keep them going. That's the underlying point. Keep them moving. Help them go through their daily activities, their motion. Taking care of yourself, learn about depression. If you know your enemy best, you want to keep your friends closer, but your enemy is more closer, they say that. Depression is an enemy. If you have depression, you're going to have that depression on and off in your life. Know that person very intimately. Put yourself first. It's not selfish. The way I tell them, my patients, if you're not good to yourself, how good are you going to be to anybody? Be it your family, be it your work, or anything else. It's not being selfish. If you're taking care of your needs in terms of making sure what works for you, that is taking care of yourself, giving yourself first important. Taking time out. You know what? It's good to take some time out. What I mean by time out is that I have to do this, I have to do that, I have to do this. Christmas is coming. My house needs to be perfectly spanking clean. My sister-in-law is coming. My mother-in-law is coming. And screw mother-in-law. No, joking aside. Why does it have to be so cookie-cut ways to meet the certain standards that we put on ourselves? Trying to please her. Time out. You know what? I'm going to do the best of it. If she doesn't like it, she can go back and she can take her son too. So, depression and co-travelers. Again, the problem with untreated depression, of course, is depression is a two-way street. It brings more illnesses. People who are depressed are more likely to suffer heart problems, more likely to get dementia, more likely to have high blood pressure, but most importantly, more likely to have poor quality of life, which can be easily treated, remedied, or cured. Right? It's a twofold increase in cardiovascular problems, independent for other risk factors. People with depression are likely to have other medical complications, as I mentioned. All other illnesses are linked with depression. Now we are finding more people with depression are more likely to suffer from diabetes, and vice versa. If you're depressed, you're not moving around. If you're not moving around, you're sitting on the couch. If you're sitting on the couch, you're watching TV. If you're watching TV, guess what you're doing? Eating. And plus, when you're depressed, everything slows down. And again, you're more likely to suffer from other comorbid conditions, be it anxiety problems, substance abuse problems, and it comes with a lot of mortality. I don't need to go that in detail. What you can do to help? Understand depression. Again, the same point. Understand depression. Understand the relation between depression and other medical illnesses. If you have other medical illnesses, be aware that you can develop depression. If you have depression, you should be aware that other medical illnesses can be there. Let me ask you a thing. Let me open the whole 15 minutes that we have about medications, questions, how to deal with things. Open. Let's talk about it. If you have any questions, any suggestions, please feel free to answer on my part. Because someone who has struggled with depression or have supported or helped someone with depression probably will have more practical knowledge to deal with it than I would know by reading books. Yes, ma'am.
Does normal insurance usually pay to see somebody like you, like a psychiatrist, or
Yeah.
how much do they pay? Do they not pay, or some?
And this again goes to the fact that the depression, look, if you have a broken bone, heart problems, hypertension, Parkinson's disease, STDs, infectious disease, you got just one insurance. Your regular insurance covers it. If you have mental illness, guess what? They outsource it. For example, I'll give you an example. Anybody working for Blue Cross Blue Shield? Good, so I can talk freely. Look, I'll give you an example of Blue Cross Blue Shield, because what they've done is, and this is applicable to all insurances, they have sublet, kind of outsource Blue Cross Blue mental health to Medula. So what happens is that even if you say that I'm taking Blue Cross Blue Shield, does not necessarily mean that Blue Cross Blue Shield is going to pay for it. You have to be approved by another small outsourced company that pays for it. And it's more bureaucracy, more paperwork in order to deal with it. So yes, when you go for a psychiatrist, make sure if you want to protect yourself from getting a big bill, make sure that your mental health or behavioral health is covered by your insurance. And how many visits do you have? It's very easy to go over the visits, like 10, 12 they offer. And then suddenly you'll wake up and a big bill coming from us or anybody else. So make sure how many visits you have. When you're buying an insurance, ask them what kind of behavioral health coverage you have. How many psychiatric visits you can get. The psychiatry is different from psychology. For example, I'll give you an example. Our own United Healthcare, we have all United Healthcare employee. Guess what? I'm the only network provider. As psychologists, Dr. Sheets, Dr. Blanchard, they're not providers. If we had to see them as our own employee, you have to pay out-of-network prices. And we try to approach them to get these people get us, Dr. Blanchard and Dr. Sheets, into the network. They don't care. They said there are enough providers out there, they don't want anybody to be more in the network. So our own employees cannot see Dr. Blanchard and Dr. Sheets. For psychiatry, yes, I'm in the network. So yes, it is very difficult unless you know how the insurance system works. And I don't expect, particularly someone who's studying for mental illness, how can they do that? And it's one more barrier. Again, another evidence that mental illness gets the short end of the stick.
Because I mean, even if you do, let's say, you had a psychotic episode, and let's say you're close to suicide and you have to go to a mental health institution, you only get 3 days. What are they going to do for you for 3 days?
Exactly. Maximum stay you get 7 days. Hey, by the time you're awake and alert, it's 3 days.
Yeah.
Another thing about our insurance here at Tech is that the ERS, the employee,
Retirement system.
no, I'm thinking about the other one, the EA.
Employee assistance program.
Anyway, they send, because we don't have our on-campus center like they have in Lubbock, they send us to Samaritan,
Samaritan Counseling
which
Center.
is not on our insurance, and if you want to follow up after the EAP,
They give you 12 visits, that's it? They give you 10 or 12 visits.
something like that.
Something like that. After that, you're on your own. And why are we not creating a heck? We are paying for the insurance. Our insurance, by the way, UHC, our insurance, I'm the only psychiatrist who takes it. Maybe 1 or 2, that's it. Most psychiatrists will not take it. Why? Pays so miserably. So you have less choices, poor quality of care. If I knew, this is business, here is academia, but if it's a business, if I know the patient is not going to go away because the patient cannot afford to go anybody else, obviously my quality of treatment will deteriorate. That doesn't happen to Blue Cross Blue Shield. Blue Cross Blue Shield has a much wider area. So know for sure that what insurance you're buying, if you're getting anything else outside it. If you're working here, you're as stuck as I am. There's no other option. And that's applicable to all state employees, not just Texas Tech. It's applicable to all, school system, everything. Well, I would recommend that but I give preference to our employees. So if you have anybody close to you, call me or email Ms. Chandler, Kim Chandler, if you can raise your hand, ma'am. Yeah. She's my associate, and by the way, she helped me with the PowerPoint. This is not my work. That's all goes to her. So we sat together and we came up with ideas. So it was a joint project. But yes, if you have anything going on, of course, I'll give special preference. I see on Saturday also, 2 Saturdays a month, I have a 12 to 6 clinic. And I kept 2 hours from 4 o'clock to 6 o'clock only for emergent patients. Someone who's in crisis, someone who cannot see me on the weekend, I see twice a month, I kept that. So yes, I can make arrangements. I can see during my lunch hour. I tend to see patients lunch hour. I can make, and if there is cancellation, I can get you in the cancellation. We can work it out. So don't stop because of availability. I know it's difficult. It's not as smooth. And we are trying to get one more faculty. Hopefully he will come by next June or maybe January, who knows. He's interviewing again in January. If he comes, we'll have another psychiatrist and significantly open more slots. We're trying. Let me hear from you, your personal experiences, barriers, problems, frustration with dealing with mental illness or depression. I know it's difficult to talk to you in public, but this is a time to talk open about it, and it's, as I can tell you from my own experience, struggling with depression, struggling seeing people who have struggled with depression, it's tough. It's not an easy illness to deal with if you don't have support.
I know you talked so much about anxiety, but is that, and you said, depression is, there's not a cure really for it. And anxiety, is that something that comes and goes, or will you still always have anxiety?
Now let me tell you about it. I didn't say depression cannot be treated. I think it takes time for depression to get treated. And also,
or cured, I guess.
Yeah, depression is a relapsing related illness. So even if you get completely so-called no indicator depression, it's very likely that second episodes or some stress comes into your life, you have relapse. Coming back to your anxiety question, yes, anxiety tends to be, if you look at the brain pathways, right? Suppose a person is very depressed and you take a picture of the brain, certain areas of the brain are highlighted more than the other, and you take a picture of another person who's suffering from anxiety, who's also very anxious, and you take a picture of the brain, you'll be amazed how similar they look, very overlapping. And by nature, there are different kinds of anxiety. By nature, anxiety also tends to wax and wane. The most common form of anxiety, as we call it, generalized anxiety, where people worry about everything. Heck, I'm worried about if I go to I go to Walmart or Albertsons, I will not have milk to buy. Now, the possibility of that happening is not zero, but very unlikely. So what I'm trying to say is that worrying about things most people would not worry about, that is a up and down condition. Medications work very good with it. Counseling works very good with it. And anxiety, particularly if untreated, can lead to depression, and vice versa. In fact, anxiety folks can be more impaired in their functioning. Be it anxiety about meeting somebody new, anxiety about talking in front of crowds, anxiety about doing anything. Heck, going outside in a crowded space, going on the freeway. It can be very disabling. So anxiety comes in different. We're going to talk about anxiety again also, because anxiety is a bigger problem in high-functioning folks like here. So we'll talk more about anxiety. But do remember the fact that treatments are safe, they're effective treatments, and the fact that anxiety can tend to fluctuate, can to come and go. You cannot say that I've been cured of anxiety, mainly because, particularly if you have a strong family history of anxiety, it will come and it will go.
Okay, my second question is, I don't know if I asked you about but the
PTSD.
Yeah, PTSD. Yeah. Does that ever go away? Stress disorder?
No, it doesn't go away. However, it can be brought to a certain extent. It stops interfering with your life. It's better than having diabetes. It's better than having, no, seriously, with diabetes, you have neuropathy, you have pain, right? You have to prick your finger 3-4 times a day. On top of that, you cannot eat your favorite food. PTSD, you don't have to stop eating your favorite food. Yes, with therapy and with counseling, it can come to a certain degree. We can control it to a certain extent that no nightmares are there. Yes, certain things can flash it back and bring it back. Yes, there's always a chance to do that. But it can be. That's the sad thing about the PTSD we see from our veterans coming up. They don't realize they have PTSD. They suffer from it. They commit suicide. They have family problems, drug abuse problems. And the fact remains that with treatment, they can get so much better, to the point that they can be functional. But yes, PTSD by nature doesn't go away completely.
So you may need to get treatment, and then it might come back up, and you might need to get treatment again or something?
Yeah, absolutely. Or they may be continuously on treatment, and they have certain relapses down, depending on how bad their symptoms are. Okay? All right, folks, I know you guys probably need to take a nap. Okay, all right, thank you so much for, yes, ma'am.
One question.
Okay.
Okay. Can you talk about the difference in anxiety and attention deficit?
Okay, very good question. The question was, how do we differentiate anxiety from attention deficit hyperactivity disorder? Now, we used to think attention deficit hyperactivity disorder, or ADHD, is a predominantly illness of children. Not anymore. We find that predominant majority of the folks who were born with ADHD, it's inborn, you cannot be getting infected with it, tend to have some symptoms of inattention and distractibility when they grow older. The problem happens with ADHD folks tend to have very high rates of anxiety. So these two conditions tend to coexist together. How can you not? If you're always concerned, if you don't have that kind of confidence that you're going to lose things, you're going to misplace things, you're going to make mistakes over here because you're going to focus, or you're going to impulsively say something, obviously you're going to get anxious. These two conditions tend to stay together. The major differentiating point with ADHD and anxiety is, of course, depending on generalized anxiety, is the response to medications. ADHD, when adequately diagnosed, which is quite easy to diagnose, is very much responsive to medications. If you use stimulants, the response is within hours, actually. It's the only condition that we can proudly say in psychiatry the response is so robust and very quick. Within hours, the bouncing around kid suddenly sits down and starts working. It's like a magic. But anxiety, and as I said, once your ADHD is controlled, anxiety symptoms get under control itself. Unlike anxiety, ADHD symptoms don't fluctuate. Anxiety symptoms tends to fluctuate. Gets better, gets worse, gets better, worse. ADHD doesn't fluctuate. If you have inattention problems, you're going to have inattention problems.
In your geriatric population, what medications do you kind of your first line medications for an older adult that's been diagnosed with depression?
Depression. It's not the choice of medication, it's about the doses of medication. Right? Everybody is different. So there's not a set particular medication that we can use that are only specified for a geriatric population. No. Same medication that we use in other populations, we tend to use in geriatric population also, but we tend to use it in very smaller dose. Because as we age, the medication, the way our body responds to medication, it tends to change. And in older population, we address not only as I said, not only the symptoms with medication, but in older population, because of complexity of life, we tend to emphasize more on psychotherapy. Dealing with losses, dealing with pain, dealing with disability, financial issues, the end of those kind of stage of life issues. That's probably more important, and that tends to neglect. That's why the effect of treatment is not as satisfactory as we would like to see, because we don't do the whole thing. We just rely on medication most of the times. Here, emphasis is mostly on medication, which is, as I said, addresses only 1/3 of the concern. 2/3 of the concern is addressed by learning new skills, how you can address certain problem that you're facing. That medications cannot do that. You have to have someone help you look at the problem from a different angle. You can be very smart, but when you're in the problem, you don't see the options available to you. A therapist who has probably half the IQ that you have has advantage in looking at the problem from outside and maybe bring up a solution. Have you thought about addressing this issue like ABC? That can be eye-opening.
Have you had some issues with Cymbalta in older people?
Yes. Well, depends on what. Cymbalta tend to use very smaller doses of Cymbalta. Cymbalta tends, in older populations, we tend to have more concerns regarding liver function test. But in terms of response, it can cause elevation of blood pressure if they already have it. Those kind of things I see more problematic in older populations than younger populations. So we tend to keep the doses very, very low. In older population, we really try to keep the medication as low as possible, mainly because how the body reacts to at that age. I'm talking about 65, 70, and older. Anybody older than 43 is much older, and anything below 43 is much younger. Did I say too much? Yes, ma'am.
You had listed on your slides Parkinson's disease. We've heard a lot
Yes.
Would depression be a symptom of Parkinson's, or is it its
Both,
own?
both. Because of Parkinson's disease, there are certain neurochemical changes happen in the body, in the brain.
Right.
That makes it more susceptible to develop depression.
Because of the chemicals?
Chemicals, absolutely chemicals. Even without depression, 90% of the patients with Parkinson's disease will develop depression. And I'm not talking about the Parkinson phase that you see, that's a part of the illness. I'm talking about separation developing Parkinson's symptoms that happens to happen because of depression. Most of the illness, most of chronic illness, endocrine illnesses, neurodegenerative conditions like Parkinson's, dementia, they affect certain neurochemicals in your brain. And the brain is all connected. If one area doesn't do well, automatically it will affect other areas of the brain, causing you to have depression. Any illness that has chronicity, that is going on for years, is bound to have depression. I don't care whether it's diabetes or it's just osteoarthritis. Okay, thank you so much. I have to go back to them. Thank you.
Could I make just a really quick comment before we use all the
Yeah.
people who are friends of when you said just do it with the exercise, that's not very helpful to somebody who's depressed. Sometimes you can't just do it.
Yes, I know. But I was hoping that, and that's where we need, even if the just do it philosophy doesn't help you, that's where to get more professional help. I totally understand. I've been there myself. But if you don't do it, what else we got?
I understand where you're coming from too, but when you're in the bottom of a depression and somebody says, well, just get up and get over it.
Yeah, no, it's very difficult. That's where the help of friends, the help of medication, the help of support system is so very important to do that. But I'm talking about mild to moderate depression. When you're really in the
Well, then, yeah,
pits,
you're right.
yeah, when you're really in the pits, it's very, very difficult. Yeah, you're absolutely right.
You were talking about medication plus counseling. Do you do the counseling or would you refer to a psychologist?
Both. It's very difficult for me to